Today, I'm going to be talking about headaches in clinic. And my general idea is to give you guys just a really broad overview about how to triage headaches in clinic, and then just going over kind of like the basics. I will tell you, I have not yet completed my neurology residency, nor am I neurology attending. So there are going to be like details in here and nuances that I'm sure I can't tell you the specifics of. If anyone has comments to add or has things they want to chime in, please do. And also please feel free to like ask all the questions. And if I don't know it, I can look it up and send an email afterwards to follow up. Okay, headaches in clinic by me. I didn't put a disclosure thing. I have none, per usual. So why we care about headaches and why we're doing this talk. So half to 2/3 of adults aged 18 to 65 had a headache in the past year. You guys may have experienced one as well. They're extremely common. And up to 47% of all people in the world have a headache disorder. So have headaches that are frequent enough that it can be diagnosed as a disorder. So it's extremely common, and that shows with our visits. So 1 to 4% of all outpatient visits are about headache, and then 2 to 3% of all ED visits. So that's actually a lot. It's very frequent, and you will be seeing this all your career, kind of regardless. Even if you go into subspecialties, you'll have patients who have headaches and are managing them. What I will say is, very few headaches are actually managed by specialists. So this is really in the internal medicine wheelhouse. Like headaches are actually ours, most of them. Few go to neurology or any other specialist. So we should know how to approach them. But I feel like this when I am thinking about how to manage a headache and how to triage, and the patient probably feels like this too. We all can kind of get a little bit nervous about how to manage them. So my hope is to simplify that today and make it so we feel a little more relaxed. So learning objectives. First, I just want us to be able to list the danger signs of headache. So when to image someone, think about imaging, and then when to think about sending them to the ED versus when a headache can be managed well in clinic. My hope is we will be able to name the characteristics and management of migraine, tension, and medication overuse headaches, and then list at least one non-medication treatment for headaches, so lifestyle or otherwise. So it's 8:10 a.m., it's your first patient of the clinic day, and you're about to walk in and see a 47-year-old woman with a headache. What kinds of questions would you ask her? And my idea is I'm going to try to put this down for you guys as you go. What questions would you guys ask?
Celia asked, is it a new headache?
Nice. New versus old. Okay. And Celia, why do you ask that?
Because I want to know if it's something that hasn't happened before.
Cool. Sounds great. Awesome. What else would you ask?
If anything, she has any like temporal relation with anything? Did anything bring it on? Any recent stress?
Triggers, recent stress.
Could also ask for location on the head or neck.
Okay.
You could ask if it wakes her up at night.
Nice. That is a good one. Wow, got lots of dashes going here. Okay.
Have many medications helped it? And on that thread, has she been taking medications for a long time if it's more chronic?
Ask the duration.
Nice. These are good. So we're getting at kind of the quality of it and possible triggers. And I'm seeing like questions around triaging it kind of. Cool. What else?
Is it positional?
Positional. Nice. And I think that was Kellen. What are you thinking about there?
Oh, I'm just thinking about if it's worse when you're lying flat, it's bad sign for elevated intracranial pressure.
Awesome. Yeah, totally. It's a great question.
Is the onset sudden, or does it kind of come on gradually?
Ooh, big. going with the big text here. Great. And then was that Emily? I'm not sure. What are you looking for there?
I guess I'm more concerned about a sudden onset kind of headache, thinking of sort of the scarier causes.
Yeah, absolutely. Absolutely. I think that's a really key question.
Then you could ask associated symptoms like lacrimation, photophobia, focal neural deficit, such things as that.
Nice. So like autonomic symptoms and neuro symptoms type stuff. What I think I missed something else you said, Ben, but yeah, great. So like helping you both triage and figure out what kind of headache it is. What else? Nice. Okay, yeah. I mean, these are a lot of the same questions that I had written down and a lot of really good questions. So the new or old, I bolded here. I really like also that that's the first one that came up with you guys, because that is kind of the key for me, which we can talk about, which can figure out if this is we can be reassured about this headache or if we should be maybe a little bit more concerned. So if it's an old headache, it's more likely to be a primary headache disorder. Versus if it's a new headache, we need to really have a little bit more suspicion and make sure we're really going into detail looking for any secondary causes. So that's a key question. And then, yeah, exactly what you guys said, like the PQRST, associated symptoms, neurologic symptoms, also systemic symptoms. So any fever, any weight loss, anything that could trigger you to like a room issue going on. I ask about family history. The reason this is mostly helpful is there's a genetic predisposition to headaches, so their threshold may just be lower. So if they have a long family history of headaches, it can help explain why they might be getting them. I also have the positional, and similarly kind of provoked by sneezing, coughing, exercise can be a way you can suss out ICP. And then on the right, I have a few more, and there could be many more here about triggers, which you guys are getting at, like life stressors, change in birth control, or any other hormonal changes, diet, exercise, a lot of other life things that can provoke. Cool. So the key first step that you were already getting at is identifying red flag symptoms and seeing, you know, is this an appropriate headache to treat in clinic versus do we need to get this person some workup? And the reason we do that, as we've already alluded to, is figuring out, is this a primary headache disorder versus is there a secondary cause of headache? This massive chart, which we don't need to read all of, shows you kind of how complex headache actually can be. There are a lot of causes of headache. On the, I guess, left side here, it's the primary headache syndromes. The most common cause of headache overall of all of these listed here is tension headache. And that's also the most common primary headache syndrome. And then migraine headache is after that. You will mostly see primary headache syndromes in clinic, but you are looking out for these secondary headache causes on the right, of which there are numerous, and of which the ones with the red stars, which may be hard to see on here, the red stars can be imminently lethal. So we definitely do not want to miss any sort of hemorrhage, meningitis, dissection, hypertensive emergency, preeclampsia, and carbon monoxide poisoning are some on the list of like, we definitely want to nail that. But there's other ones here in the secondary cause that are life-threatening and function-threatening in the both acute and long-term. So masses, strokes, glaucoma, OSA, vascular disease. There are a lot of causes of headache that we need to be on the lookout for. So how do we figure out if we're dealing with a primary headache syndrome and we can be really reassured versus if we need to do some more digging? So I kind of broke these down into red flag symptoms that you need to think about to send someone to the ED versus ones you need to think about imaging. So first, just going over symptoms for sending someone to the ED. I would think about this from clinic if they had a sudden onset headache that peaks within seconds to 1 minute, i.e. a thunderclap. Because just like you guys were saying, it would make you think about some sort of bleed that could be either sentinel or a ruptured aneurysm. I would send them even if the headache is better. I would still send them if they describe something like that to me. If someone has a headache with neurologic deficits, it could suggest increased ICP or a mass. The timing of this, you know, whether they should go to the ED versus get more urgent workup can be a little more nuanced depending on the progression and rapidity of the neurologic deficits, but I would just think about sending to the ED if they're having significant neurologic deficit or it's progressing rapidly. If you suspect meningitis, fever, altered mental status, plus minus musical rigidity. If someone has visual impairment or eye pain, this can be suggestive of acute angle closure glaucoma, which is an ophthalmologic emergency. Again, very rare cause of headache, but can cause someone to lose their vision. Or they could have optic neuritis, uveitis, and they should really either go to the ED or be seen by an ophthalmologist in clinic that day. And then again, possible carbon monoxide exposure. I did not have that on my differential for a headache before putting together this talk, and it is extremely rare, but can be life-threatening. So it's nice to have in the back of our mind. If someone, based on their work environment, or I don't know, they're grilling in their home or something, has an exposure. Great. Red flag symptoms to think about getting imaging. So not quite as emergent, but you want to look for other causes. If someone has systemic symptoms, so weight loss or fever, or honestly, those are the big two, early satiety, any of the like B symptoms that turn you on to something systemically going wrong. I also kind of grouped in here, this is not totally fair, but in my mind, I kind of put immunosuppressed in that category too, because you want to have a like higher index of suspicion for patients who might be predisposed to infection that could present in subtle ways. So I have a lower threshold for imaging someone who's immunosuppressed with a headache. Anyone with a new headache after age 50 should get imaging. And by imaging, I mean, I should clarify, you guys, sorry, mostly it's a brain MRI if we're going from clinic. Some of the more emergent causes, which we talked about last slide, might be a CT, but mostly we're talking brain MRI. If someone has a pattern change of their headache, so let's say they usually get like one-sided migraines, they've been getting them all their life, and all of a sudden they are getting these two-sided, like severe headaches that are lasting much longer. That would be something that could trigger you to get imaging, just like you guys brought up, if it's positional, wondering about ICP. And in particular, you want imaging before you may get an LP to work up for elevated ICP, just to see if there is a mass and if it's safe to do an LP. Similar to pattern change, if it's progressive, if it's getting worse over time. And then post-traumatic, having a low threshold if something happened to their head. In particular, of course, for our older patients, people on anticoagulation. Like that. Any questions before we do some practice cases? Cool. I'm going to be extremely cruel and just run down people by name to go through these practice cases so we get even distribution. You can provide horrible feedback to me if this is the worst. And also anyone please pass if you don't want to participate. Don't worry about not knowing. We are all in this together. So I'm going to start with Arjun. If you're here, if you saw a 65-year-old in clinic, 2 weeks of headache, difficulty reaching overhead, pain with chewing, how would you think about triaging this person? Would they go to the ED, imaging, fine to do in clinic?
I mean, as far as triage, the only thing that's coming to mind is like with the difficulty reaching overhead, like some sort of subclavian stenosis maybe, but I don't know if that really is the answer. And I know people who've had that and it wasn't urgent. So I wouldn't be sure if I would send them to the ED, especially, I guess, 2 weeks. Yeah, I think it's okay with just some coming into clinic today and setting on imaging, but I could be completely wrong.
Yeah, no, it's tricky. And I think with this one especially, it's hard to suss out these symptoms sometimes because it's like nuanced. If people are having pain with chewing or trouble reaching overhead, it's kind of hard to get someone to talk about that. But some of these are keywords for giant cell arteritis or temporal arteritis. And I would want to think about in this person steroids and then getting them either to clinic, I don't know who does it these days, I think it's optho, versus the ED for a temporal artery biopsy. And again, this is one, and this is why I'm kind of going over these, is the 2 weeks of headache is like, it's not that concerning in terms of like an acute bleed or something, but it's someone over 50 with a new headache and these associated systemic symptoms that can trigger you to think about something else going on. Cool, thank you so much for participating. Ben, if you had a 45-year-old sudden onset severe headache 4 days ago, and now has dull pain and some neck stiffness, but feeling not too bad, what might you do?
They're 45, so they're less than 50, but I guess it's a little concerning that it's sudden onset and they have some neck stiffness. So should think about dissection, if they had like a chiropractor appointment or trauma. But then also with the neck stiffness, if they had any fever or anything or confusion, you could start thinking about meningitis.
Yeah, totally. Exactly. I totally agree with all of what you said. And I would also add to that list, like a sentinel bleed of possibly an aneurysm or subarachnoid or something, where you can get that sudden onset kind of thunderclap headache, but it can get better over time. So I would probably send this person to the ED for imaging, unless I could get it in some other way, like that day, probably. That's what I would do. And again, you guys, there are nuances to this, but it's kind of the general idea. Cool, thank you. Celia, you guys can really punish me if this is the worst calling people out. I just want to make sure like everyone is okay participating. Celia, 35-year-old, new headache, some lower extremity weakness for 4 weeks. How would you triage this in clinic?
The headache is newer than the weakness?
I would say the headache and weakness have been going on for about the same amount of time.
New headaches are scary. She can go to the emergency department.
Nice. I think that's totally reasonable and totally appropriate. I agree. And in particular in this one, the worrisome thing is the weakness, like kind of one area of weakness that's new. If you're a 35-year-old with a new headache and no other neurologic symptoms, plus minus, you could give that some time. I said in this one, like, you might want to just see if there's any sort of maybe a mass lesion or something causing that neurologic finding. You wouldn't necessarily need to send them to the ED depending on the progression, though it's totally appropriate to do it. You could also just see if you can get some imaging in a timely fashion for it. Cool, thank you. Dan, a 70-year-old, left-sided headache, left eye is red, and there's vision loss in that left eye, I should say.
I'm guessing this is pretty acute, so I'd be concerned for acute glaucoma. So probably would send them down to the ED to get some treatment.
Yeah, nice. That sounds good to me. Yeah, if you have one of those little tono pens, you can use it. I don't know if we have one in our clinic. They definitely have them in the ED. And then, yeah, exactly what you said. Like, they should see an ophthalmologist one way or another that day. So the ED or ophtho clinic. Awesome, thank you. Emily, 55-year-old, new headache, no neurologic system symptoms. It's just like, they got a new headache.
Yeah, so I guess, I mean, new in a person of that demographic makes me think that we should get imaging, but I feel like we could probably do that on an outpatient basis.
Yeah, I totally agree. Exactly. Imaging does not need to be emergent, but you should just kind of go snooping around and see if there's any secondary cause. Awesome. Thank you guys for doing that. So kind of the ways I tried to summarize this and make it pretty simple is, one, as you guys are already doing, for all patients, just think about new versus old. And that's a nice way to be easily reassured if it's old, it's been going on for a long time, versus if it's new, we should put a little more we should always put thought into it, but make sure you're really thinking deeply about what could be causing the headache. And then in particular, have concern and low threshold for imaging or referral for if it's new in age over 50, if there are any systemic or neurologic symptoms, and then if it's positional. There's a mnemonic, it's like Snoop with many P's, that you can also look up that has kind of a more detailed list of reasons to image or refer, but this is kind of my like simplified system. Before I move on, what questions do you guys have about triaging? Any concerns? Have you had tough headaches in clinic that don't quite fit into this?
So I had a patient, 27, 1 week of neck pain and headache with periodic numbness in both hands. So neurologic symptoms theoretically, but also neck pain, headache, kind of intermittently worse at certain points. The neck pain is always associated with the headache. I guess how scary is that? And should I not have been like, hey, take some Flexerol, you'll be good?
Well, I guess one question, I'll just put it like back to you. What did you guys do? First of all, what was your concern and what did you do for them?
So because it had only been going on a week, initially we wanted to try, we thought it was tension headache. So we tried a little Flexerol because new, working from home, maybe not the best ergonomic office setup. And the headache was always associated with the neck pain.
Yeah.
Which is occipital.
Yeah.
And Sperling tests were negative.
Nice.
And full range of motion, no systemic symptoms. It was just the periodic tingling. So we treated with stretching, some Flexerol, some ibuprofen, and said follow up.
Yeah. I mean, it sounds like you guys kind of walked through, okay, is there any reason that like something could be life-threatening? So that it sounds like there were no symptoms of like a bleed or something really acutely going on, infection, anything like that. And then the neurologic symptoms you sussed out. So like looking for neck stuff, looking for any other causes. The one thing that sticks out to me about the description of the neurologic symptoms is that you said it's in both hands, which it's a tricky pattern to get if you're thinking about anatomy wise, thinking about a mass or something going on. So I think it makes sense. It sounds like what you guys did, not that I don't know anything about this patient, but I think that case gets to kind of the nuances of sussing out what is a neurologic symptom. And it can be tricky because people can get numbness and tingling in different distributions. And maybe one take home point from that is trying to think about, are those symptoms actually in a distribution that makes sense from an anatomy perspective? Cool.
Yeah, that makes sense. Yeah, we said follow up, it's not getting better because young patient, new headache, we were worried about some kind of mass, but didn't necessarily feel that imaging was warranted to start.
That makes total sense. I mean, I guess that's like a primary care classic move, which is follow up and see how you're doing. Cool. Nice. Any other questions before I move on? Okay. Cool. All right. So it's 8:25 a.m. You have chatted for 15 minutes with your patient, and you have found out that she's healthy in her past medical history. She's had these headaches since she was in her 20s. She recently went through a divorce and noticed her headaches are worsening, and in particular, they're just like becoming more frequent to the point that they're now daily. They last 8 hours. They're bilateral over her kind of entire head, throbbing in nature with some photophobia and phonophobia, no aura. She denies nausea, vomiting, no positional aspect to her headache, no weakness, numbness, fever, weight loss, vision changes, anything like that. And she's been treating it for the last 3 months because it's been worsening for a while, for the last 3 months with 600 milligrams twice a day of ibuprofen every single day. And that's not particularly helping her a lot. So, oops, I went forward. Are we dealing with a primary or a secondary headache? What do you guys think about this? And maybe I'm just going to continue this. Like Jed, what are your thoughts on just reading this?
It's an old headache.
Mm-hmm.
And it seems like it's aggravated by the things that might make a tension type headache worse.
Mm-hmm.
Also, she's taking a lot of ibuprofen every day, so it could be a medication overuse headache.
Nice.
So if I was to counsel her, I would say try stopping the ibuprofen. Trust me, for once. and if it doesn't get better, come back in a week and we'll see if we can. Oh,
Nice. I think I heard you. Yeah. So I hear you identifying that you are less concerned. It sounds like more likely this is a primary headache disorder, which also per my clicking, I clearly agree with. So we can feel more reassured we can handle this in clinic, but exactly now what? How do we diagnose her? How do we understand what primary headache this could be? So going through the two major causes of primary headache you will see. Again, there are a few others that fit into this category. Cluster is the third one that's often listed, but like cluster is like less than 1% of headaches that you will see. It's just quite rare. So I'm not going to talk about in detail, but just keeping in mind, I think Ben brought up the like looking for autonomic symptoms or one-sided symptoms is something that might trigger you more towards cluster. But we are going to look at migraine versus tension. So migraine, most of the time it's unilateral, 70% of the time, bilateral in 30% of cases, whereas tension tends to be bilateral almost all of the time. Migraine is gradual onset, tends to kind of crescendo, like it builds to its peak. It's pulsating in nature and is moderate to quite severe in intensity. I imagine some of you have yourselves or family members who experience migraines and know how debilitating they can be. Whereas tension tends to be more like pressure or tightness in nature and can wax and wane even throughout one single headache episode. Migraine, people prefer to rest, maybe a dark, quiet room, whereas tension, sometimes activity can help. So people may preferentially be active during their headache, whereas also rest is better for some people. Migraines last for 4 hours to 3 days. Tension headaches are from 30 minutes to up to 7 days, or honestly, I've heard of even longer. So they are quite long and can also be really obviously significant and debilitating for people, just like migraines. Migraines have all these associated symptoms you guys alluded to. So aura, the most common aura is a visual aura. It's called, often it's a scotoma, a little area of vision loss. People can also get sensory auras where they'll feel something, motor auras. There's something called hemiplegic migraine where people actually have like facial weakness or hemiplegia, very rare. And then some people, can get other auras, but honestly, it's mostly visual. Nausea, vomiting, photophobia, or phonophobia. Tension headaches tend to be just the headache, no other associated symptoms necessarily. Though as Talisha brought up, you can have like neck pain and tension elsewhere in the body. And I don't know, possibly bilateral hand tingling and other things. This is definitely not to say people can't have any associated symptoms, but it's less common. In terms of, I'll just speak really briefly to the pathophysiology, briefly because I think we don't know a lot and I can't go into like the nuances of it. So on the migraine side, there used to be the theory that it was caused by vasodilation of the intracerebral vessels. That is now not in favor. The thought is maybe there's some like trigeminal nerve activation. There's a lot of like cortical activation of neurons. There's some other stuff with serotonin and like calcitonin gene receptor things that are beyond me, but I think we're really still trying to understand what causes migraine. And I was surprised to learn that tension headache, we know even less about what causes tension headache. In my reading, looking up for this, I couldn't find any really great explanations. Just briefly, like the reason it's kind of hard to suss out what causes headaches is, well, one, it's hard to study the brain, but also the brain itself doesn't have any, like, it doesn't sense pain. So it's got to be other things in and around the brain, and it's hard to suss out what's causing that. Okay, so this is a brief mind break video interlude. If I can play it, no, let me see if I can do this. I'll play it from here. Oh, okay, I'll have to send this out. It worked when I tried it myself, but I guess not on Zoom. basically the Mayo Clinic decided to make a video of a scotoma appearing on a sunny day and ruining the afternoon, they talked about. But you can see here the basic idea is this is what a scotoma looks like. It's an area of vision loss. Often that kind of right side will be shimmery and it will move and it will kind of grow in size and then go away. It can last for several minutes to even up to hours. And as you can tell, if someone has this in the middle of their vision, it can be a little scary if you're driving or doing other things. And as Jed alluded to, I want to make sure to talk about medication overuse headache. It's not necessarily like a primary headache syndrome, but it is mixed in with the two of them and can be quite, well, I can't speak to how common it is. There's some idea that it's overdiagnosed, but it can definitely affect your patients. So it's tricky to actually diagnose because often people who have primary headache disorders are taking lots of medications to try to help themselves feel better. And you can actually get these medication overuse headaches. The general hand waving mechanism is they lower the headache threshold over time. To diagnose it, you actually have to use a lot of medication. So you have to have headaches over 15 days per month with a history of more than 3 months of taking abortive medications at least 10 days out of the month. So lots of medications for a long time. Characteristics, often they occur in the morning. They can have, it can feel a lot of different ways. It can be like a migraine, it can be like a tension headache. It runs the gamut, which again makes it hard to diagnose. They're often transiently relieved with abortive medications, but not fully, which can perpetuate the cycle then of taking more and more abortive medications. And they can be caused by a wide variety of meds. So really any of the abortive meds, Tylenol, NSAIDs, triptans, ergots, any of the combination analgesics that have some caffeine in them, opioids, any of those guys. The bottom line of what I advise for people in primary care is you just want to look out for, just like Jed was saying, anyone taking a lot of medication and really help them cut back so they're not worsening their headaches. Even if you can't suss out exactly, is this a medication overuse headache, just making sure you're helping people cut back, and we'll talk about how much is recommended. Questions before I move on? Comments, things to add? Okay, cool. So it's 8:26 a.m. It's 1 minute later. You've thought about what you think she has. Let's say Kellen, how, now having gone through the primary headache disorders, how would you characterize your patient's headache?
Well, it's lasting 8 hours, bilateral and throbbing, and with photophobia. That sounds like a migraine to me.
Nice.
And her ibuprofen use, we don't know how long she's been taking it, but I'm guessing it's not 1 month. Is that what you said?
4 months. Let's say a long
4 months. Oh no.
Yeah,
okay. I still think it's more consistent with a migraine, but it's still possible.
Yeah. Yeah. Awesome. Exactly. She's got a lot of features that could be a little bit mixed, like the bilateral sort of tensiony, but she definitely has the photophobia, exactly, definite migraine characteristics, and then is a candidate for medication overuse contributing to her daily headaches for sure. And I tried to make her a little bit of a mixed case because people don't stick to one class of headache or the other. They can get all sorts of mixed types of headaches. So, but I agree with you. She leans towards the migraine and she's taking a lot of meds. So what headache syndromes, and then how can we help her? Let us find out. So the first thing I really wanted to highlight is for every person who has headache, it's just really important to take the time to counsel on lifestyle changes, because these are the things that can really trigger headaches and can have the best long-term outcomes. The meds, which we'll talk about, and as we just talked about with medication overuse headache, in the long run can lower your threshold for having headaches. So the things that help over time are lifestyle changes, which are most of what we advise patients to do regardless of what diagnosis they have. So getting regular sleep, 8 hours every night as much as possible. Getting regular exercise. There's no specific amount I saw that you can advise patients. I would just tell them that like 150 minutes a week, 30 minutes a few times a week. There was some suggestion when I was reading that maybe cardio is more helpful, but I don't think there have been rigorous studies about this exactly. Decreasing caffeine use. So caffeine can be a trigger. They're drinking a bunch of coffee, you know, they don't have to cut it out, just trying to cut down and see if this will help. And then if they're drinking 1 cup a day, you can ask them if they want to cut down to 0. Managing stress as you're able. It's easy to tell people and hard to do in practice. Trying to figure out, like, help things in their life to help them manage the stress. So whether they can work on changing environments or whatever is causing it. And then promoting mindfulness. So Headspace app, Calm app, breathing exercises, exercise, whatever it is that calms them down. I have stolen a dot phrase from the neurologist about like things to advise, lifestyle changes to advise patients on. And they literally have as a bullet point in there, have fun, like make sure you are enjoying life, having fun, trying to get away from your stress as much as possible. And then eating regular meals, not skipping meals, which can be a trigger for headaches. And then lastly, this isn't quite lifestyle changes, but just look at the rest of the meds that they're taking. So hormones or hormonal therapy of all kinds can trigger headaches. So if they have a new OCP they just started, any postmenopausal hormone therapy that has changed dose or just been started, if someone is trans or non-binary and they have been recently started on hormones, that can trigger headaches. Nasal decongestants, SSRIs, PPIs, that stuff. So if possible, trying to either switch meds from these classes or eliminate them if they're not needed. Key with lifestyle changes, as always, it takes time. The key with headaches overall is any of the changes we make and any of the treatments we make take time. So I think really advising your patients that these changes will help. It will just likely take months, and having regular check-ins with them can be quite helpful. Cool. Abortive medications. So if we're gonna do meds, which we definitely should think about because headaches are really tough, there's a whole list of abortive medications. I stole this there's a great New England Journal review of migraines from 2017, which I encourage you to look up. I stole this from there. We're not gonna like walk through the whole chart. I do wanna say before I get into it, like I said, it's for migraines. So for tension headaches, there are even fewer options in this chart because we really don't understand the mechanism of what causes them. So it's hard to figure out something to target. Most of what people use is NSAIDs or Tylenol, or some of the combo meds where you have like an NSAID, Tylenol, caffeine in them. As we've already talked about, this can make you prone to medication overuse headaches. So really pushing the lifestyle changes and trying to get them to limit how often they use these meds. I would say anyone using abortive meds more than 6 to 8 times per month is really at risk of getting medication overuse, even though by definition it's 10 times. I think you're getting into an area where you could be worsening your headaches. So really these are abortive for migraine, which I've listed. There's a whole long list. The bottom ones, like the single pulse, it's like a cephalate device, and some of these fancy new meds are where the neurologists do their magic. But we in primary care really prescribe a lot of these. So we've got the triptans and the ergots, which both work by trying vasoconstriction. So they're kind of within this old paradigm of how we used to understand migraines and targeted that. Nevertheless, they still help. I would say for both of them, and we'll talk about it, contraindications are CAD or any sort of vascular disease because they can cause some vasoconstriction. Tylenol, NSAIDs, the combination meds, which we already talked about. And then antiemetic agents can be helpful. You'll see this a lot in the ED. Someone will get Reglan to improve their severe headache. You can also use it as an outpatient, as well as prochlorperazine, especially if someone has nausea. Zofran can help with nausea associated with headache, but I think is less helpful at actually stopping the headache. What I do want to point out though here is that in this chart, it talks about the pain, like the effectiveness by 2 hours of having pain relief, and none of them are that awesome. Like the best one is the triptan, which says the most is that 50% of people will have some pain relief at 2 hours, but it can go as low as 16%. And all the other meds really hover around like 15 to 30% have relief by 2 hours. So this is, but like these meds are not a quick and easy fix by any means. And as I keep saying, if using, honestly 4 times or more per month, but really 6 to 8 as well, you should consider a prophylactic medication, which we'll talk about. So how I use these. First step, I usually go to the triptans. Like we just saw, they can have pain relief at 2 hours in up to 51% of patients, so maybe the most effective. And some people get total cessation of their headache. They work really awesome for some patients. Contraindicated in those with CAD because of this vasoconstrictive risk. And then next, I also advise people to try the NSAIDs, Tylenol, or the combo meds. Some people respond better to the combination medication. So let's say if someone's, using naproxen 3 times a month, it's not really helping. You could try them on one of the like Tylenol, NSAID, caffeine combos and just see if they respond better. The issue with these is in particular the caffeine, and having all of them together make them prone to overuse. If that doesn't work, we can then go to the ergots. What's nice about these is there's an intranasal DHE, and so it can make it easy to use if people have nausea or vomiting, and up to 40% of people can have pain relief at 2 hours. Again, contraindicated in CAD, and peripheral vascular disease is on the label that you should not give it to patients who have that. And then neurologists do fancier things. By the time I've kind of run through these, if someone's still having a lot of issues, 1, I'll be thinking about prophylactic medication, and 2, I would probably be sending them to neurology for more help. Cool. Pause for questions on abortive medications.
These abortive, go ahead, Mac.
Oh, no, you can go, Kellen.
You're so nice. All right. For these abortive medications, that's for not only migraines, but also for tension headaches. Is that right?
So it's like confusing. Sorry, like put this in a weird way. The whole list here, I wish I could use my hand or had a pointer. I would say the Tylenol and NSAIDs and the combination meds, so like the Tylenol, aspirin, caffeine, those can all be used for tension headaches, but really like the triptans and ergots, they're not usually used. Some people with migraines also have tension headaches, and they find that the triptan can help with their tension headache, so they take it, which is totally fine. I generally don't prescribe triptans for like people with pure tension headache, and that doesn't seem to be the practice based on my reading of other people as well. But yeah, I don't know, maybe it's worth a try if you're desperate. I would just really, really try to figure out about the lifestyle stuff.
I'm not sure if this is like common practice among neurologists, but for the neurologists that I scribed for, they would say, especially for the abortive therapy with the triptans and the ergots, to even for people who feel like a little bit off during the day, to have a super low threshold of using them, because they do have that variable efficacy and they take a while to come on.
Yes.
And found that a lot of patients, if they waited until they actually had like a full-on migraine, that it wasn't really useful at all.
Yeah.
And I feel like we had lots of patients who felt as though just like kind of awareness and acting sooner rather than later really helped them out.
Awesome. Thank you, Mac, for bringing that up. That is, such a key point. I echo what you said. People generally have a sense, especially if they have the aura, of when it's coming on. So having that low threshold of taking it. Thank you. Other questions or comments?
Have you heard the like, not like myth, or the kind of like the idea that sinus headaches are actually just migraines?
Oh my gosh, I don't know. I can't say that I know the nuances of that. Will you?
I guess, I mean, I think it was on an ACP presentation that I'd seen, and I actually think it was Dr. Pao who was talking about, especially for patients who are coming in and they have these quote unquote sinus headaches over the years, we misattribute them to sinus pressure when there's actually nothing significant going on, and we miss the opportunity to treat migraines. And so,
Cool, that's a nice little pearl. It's just kind of stepping back and reassessing, and maybe trying some migraine treatments in those patients, it sounds like. Awesome, thank you. Okay. move through all this. Prophylactic medications. I want to be very clear, this is just for patients with migraine. There is like no necessarily prophylactic medication that I use or that I could find used for tension headaches. So when do we use them? No strict criteria, but consider for patients with migraine, if they're having more than 4 migraines per month is when you should really start thinking about it. If their migraines are very severe, where even if they're getting 1 a month, but it is just so debilitating and they're open to taking a pill every day to prevent it, that's totally a reasonable time to consider prophylactic. Or if they have little response to abortive medication. And again, if they themselves are interested in taking a daily medication to try to prevent migraines. So again, stolen chart from the great New England Journal Review. This is, again, a lot to read and a lot to use. And what I will say is the neurologists generally do way more than we do in primary care. So I tend to stick to this area, these top 3, TCA, beta blockers, anticonvulsants, specifically topiramate. It's what I've mostly seen other primary care docs use as well. There are other options like divalproate, and you can read down the list. Botox is very common. I've seen some family med practitioners do Botox injections for headache, but generally in primary care, we stick to the top of this list. So that is what I will review. Just before I move on, I want to note at the bottom, you may be seeing more and more patients on this. So there are these new monoclonal antibodies targeting, it's this like calcitonin gene receptor protein, which I guess plays a role in a lot of signaling or sensory in the head and sensory nerves in the head and neck. So you'll be seeing more patients on these meds listed at the bottom, but I've never prescribed them. So prophylactic medications that we use in primary care, TCAs, beta blockers, and topiramate. In terms of the risk benefits, so the TCAs are nice because they can help people sleep in particular, so they're good for patients with insomnia. Side effects are the anticholinergics and weight gain, as well as some sedation as well. The beta blockers, you probably use them commonly for other indications. They're especially helpful for people who have anxiety or possibly hypertension, though, as we know, they're not necessarily awesome treatments for that, the ones we would use for headache. I would avoid them in people with low blood pressure, low heart rate, or exercise intolerance. And then topiramate is a nice choice for people in particular. One, I honestly use it pretty widely for anybody. I think it can be quite effective, but 2, it's really nice in people who are trying to lose weight. The funding and reimbursement for weight loss medications is kind of a whole other topic and can be tricky to get covered. So it's really nice if someone's trying to lose weight and has headaches, and you can prescribe them the topiramate for the headache. It can really have that double use and get paid for. In terms of effectiveness, you can look on kind of the reported mean monthly therapeutic effects and see one for TCAs, I guess, as of 2017, and from what I could find, there wasn't tons of data available. I'm sure a deeper dig would find it, but I couldn't find exactly how effective they are. Anecdotally, some people find them quite effective, but that's anecdote. For beta blockers, they reduce headache days by, I think, half a day per month. And then for the topiramate, it looks like anywhere from basically 1 to 3 fewer days with headache. So again, kind of like abortive meds, helpful, for some people very helpful, but not a magic solution by any means. The thing I want to mention with topiramate is that it can make people feel really slow and sluggish. So some people do not tolerate it at all, but some people tolerate it just fine. But I wanted to make sure to mention that so you tell your patients. Supplements. So neurologists also recommend a lot of these supplements to patients. And what's nice about them, in my understanding, is that they can help with headaches without lowering the headache threshold. So unlike the abortive meds, they can help and even be abortive, but don't make you more prone to headache. So just to list them here so we're familiar, I don't have a lot of patients who have used them, but they are recommended by the neurologist. There's Boswellia. It's an herb that you take in a pill. They recommend sleep modulation with melatonin, so 5 to 10 milligrams at night. You'll notice here they recommend it 30 minutes prior to sleep. So that's closer to sleep than we recommend it for actually helping someone get to sleep. But I guess the idea is that it just supplements their sleep and makes them have a better quality sleep. Feverfew tea, 1 to 3 cups a day. And then magnesium citrate. So starting at 250 milligrams, up titrate basically for what you can tolerate until you get diarrhea, up to 500 to 1,000 milligrams a day. I have a dot phrase, CRAVS headache. Please feel free to steal it. It has all this stuff and more that I stole from neurologists. So go for it. Okay, questions. I know we're getting near the end here. No, okay, so we are back to our patient. What would we recommend? And maybe I'll go through a few people and just ask for one thing you would recommend. So Kevin, what was something you would tell her?
It sounded like the divorce is a key thing, so I'd want to talk about stress control and how that's going for her and what options we have to help her deal with it.
Yeah, awesome. I like that a lot. Sweet. Mac, do you have something else to add?
Probably looking at that ibuprofen amount that she's taking, and going off on that.
Yeah, and that's a tricky question. Like, how would you advise her to stop that? Anyone can chime in. How would you advise her to stop that? How long do you think until you see improvements after stopping ibuprofen?
I have no idea.
That's yeah. Anyone else can? I would say so. Like, it probably depends by person. Sometimes if people have really bad medication overuse headaches, they do this inpatient, but most times it's outpatient. And I would just say stop cold turkey. The headaches are going to be worse for even up to a few months, but they will get better. And it's just kind of this horrible transition that people have to go through that will help eventually. Cool. Maria, do you have anything else you'd want to recommend?
I mean, so it sounds like with the photophobia and phonophobia, that reminds me a little bit more of like migraines. So I also just want to know, like, if she has a family history of migraines or if she's ever used any like abortive medications before, and potentially think about first stopping or lowering her use of like ibuprofen, and then also thinking about maybe like adding in a different abortive medication or prophylaxis.
Awesome. Yeah, I totally agree. Like, the triptans we know can be more helpful for migraines, but also she is an awesome candidate for prophylactic meds too, which may or may not help with that transition coming off of the ibuprofen if she does have some medication overuse. Cool. Anyone else near the end of the alphabet with other things they wanted to add? No.
Should we check a BMP because she's been taking so much NSAIDs?
That sounds great to me. I like it. Yeah, make sure she's doing okay. You will have checked her blood pressure too. It's a lot of it NSAIDs. I mean, like, it's kind of a sort of regular amount, but it's for a long time. Yeah, so I totally agree with what you guys have said. Support in any way we can, managing stress of divorce, connecting with a therapist, ensuring good diet, exercise. And again, I say this not to like, there's a risk of being dismissive of patients' pain, and I don't want to do that, but it also is helpful for them in the long run to have these other supporting parts of their life. Stop using ibuprofen, good candidate for daily prophylactic. I would think about maybe a beta blocker in her if she's healthy and nothing else going on, or topiramate. And then, yes, love the idea of switching to triptans if she does need an abortive. But again, really trying not to do that more than 6 times per month. Cool. Any questions before I kind of make a last point and wrap up? Okay. I just wanted briefly to talk about disparities in headache care, and this is by no means a thorough review. This is mostly from one review paper looking at differences in African-American patients and Caucasian Americans in how their headaches are diagnosed and cared for. And I use that vocabulary just because that's what was used in the paper and the vocabulary that was used in the studies. So this review found that African Americans have lower rates of migraine than Caucasian Americans. There's a question if there's maybe an underdiagnosis because they might present a little bit differently with less nausea or other associated symptoms leading to underdiagnosis of migraine. But it seems like African Americans who do have headaches may experience more severe or more frequent headaches and are less likely to continue clinic-based headache treatments, even though the clinic-based treatments are equally effective for both African American and Caucasian patients. And that stood when it was corrected for socioeconomic status. So it kind of makes us wonder, and they wondered in the review, but of course could not exactly nail down the cause, but makes us wonder about if they're being discouraged from continuing treatment because maybe there are fewer providers who look like them, because of their experience in the healthcare setting or feeling dismissed, or because maybe they're actually getting undertreated. There was data they found also that they mentioned that African American patients are less likely to receive care for migraine in primary care setting. So it's less likely to be diagnosed and identified as an issue, and then less likely to be prescribed abortive medication. It was like 14% of African American patients with migraine, I believe, and 37% of Caucasian Americans with migraine. For me, this just brings up like, migraine is a pain syndrome, and there's data in other realms that we undertreat pain in patients of color. So I think just trying to be sensitive of making sure we listen to people's stories, really not dismissing them, keeping an eye out for migraines in patients of color and trying not to underdiagnose it, and then really thinking carefully about how we're prescribing pain medications and trying to address our own biases and how we may underprescribe inadvertently to patients of color. There's a video that looked at healthcare disparities in migraine and headache care. There's a really nice panel discussion with some patients that I have the link there, but you can check it out if you want. That's it. We are done. Any other questions before I cede the stage to Helen?